Good morning, one and all. So my talk for the day for 10 minutes is epimacular membrane, the various types, manifestations, and management. So Fuchs was the first to etiologically classify it. The first two he did describe, saying it was primary where there was no etiological factor as such, idiopathic or age-related. And the second was secondary because of various causes which predisposes the eye to go into an inflammatory state and form the macular membranes. The recent one, there has been an acronym which is called as LHEP, that is lamellar hole associated epiretinal proliferation, which has come into the recent years from the past 2 years. I'll just deal with that also. So when you look into the etiology part of it, as Fuchs had already given, the idiopathic, which is, I'll prove over a period of the next few slides about the age related, and the secondary, which is a gamut of various intraocular conditions like retinal vein occlusion, inflammatory conditions like uveitis, tumor associated, any intraocular surgeries inclusive of VR surgeries, or cryo or laser can predispose to the formation of epimacular membranes. So as far as the epidemiology is concerned, when we look at eyes more than 50 years having epimacular membranes, about 2% in international literature, and when we step up that age criteria to 75 years, it becomes 20%. So it's an indirect evidence to suggest that these idiopathic membranes are more so age related. Other common ones like macular pucker, which is commonly seen in post-VR surgery, especially retinal detachment surgery, is about 3 to 8.5%. Bilateral cases, one eye, if you have an idiopathic macular membrane, there is a high probability that the other eye might also have. It's about 20 to 30% of the cases. So one of the first clinical criteria for this was given by Gas. This was to grade the patient and to see whether the patient needs a surgical intervention or not. He divided into 3 simple stages. Grade 0, which is a transparent, what we call as cellophane maculopathy with no visual consequences. The patient comes for a daily routine examination and you tend to pick up this membrane. A grade 1, where you have a fine retinal folds, patient might complain of some amount of metamorphopsia. The grade 2 are the ones which the Gas recommended for surgical intervention, where there is a marked distortion and wrinkling of the retina, which causes secondary changes in the retina, which includes hemorrhages, edema of the retina, cottonwool spots, and localized serous detachment. So how do we generally deal with this membrane? This is all well known, but I'm just repeating it. So one of the first which most of us do nowadays is, which has already been talked about in the previous IC, where we generally go and stain the posterior pole with the BBG, and there is a positive area of staining and a negative area. The negative area is generally the ERM. So what we do is we start with the positive stained area, that's the ILM, and peel all across the fovea. So it takes care of both the ILM as well as the ERM per se. So the general extent of peeling would be as good as the ERM. So you need not do an extensive peeling like in giant macular holes. So an area sufficient enough to cover the ERM is good enough. Or you can go in the conventional way, which was taught to us. First you identify one of the edge of the epimacular membrane, lift it up gently with a 24 gauge needle or a barbed MVR blade, and then go and peel it all across the macula. Once you finish this, then you stain the residual ILM over there with the BBG and then do the ILM peeling. ILM peeling came into vogue to prevent the recurrence of epimacular membrane, which was very well taken up by all of us. I'll just come to the other evidences which goes against it. This completes the surgery of ILM peeling along with the ERM. So what if there is a macular hole? If there is an epimacular membrane along with a macular hole concomitant? Nowadays there is a statement which even my boss keeps telling, that macular hole has become a dustbin surgery. So whatever you get, you go and fill it up. So what we call as the inverted flap, we are trying to extrapolate it in putting all sorts of membranes. So even these days we can try and put the epimacular membrane also. This is a patient who has a macular hole concomitant with an ERM. So what basically I'm doing is peeling the ILM and the ERM together and taking it to the center and leaving it as, so that it acts as a scaffold for the macular hole to close upon. So you don't need a separate tissue. It's not that you peel the ERM, then you peel the ILM and stuff the ILM. You can stuff the ERM. It's not basically stuffing, it's just overlaying onto the macrolome and leaving it with gas. So basically, essentially, it completes the surgery, do an air fluid exchange, and leave for the scaffold to act for the macular hole to close. So a big dilemma or the question which has risen up, we have n number of articles to support that if you peel the ILM along with your ERM, definitely the recurrence rate comes down drastically. There is already comparison trials saying that about 70 to 20% of the ERM recur if the ILM is not peeled. But at the same moment, we have now recent articles saying that if you peel in every case, there are these end-phase imaging of these patients when we do, there is large amount of these lacunae which appear. These are folds, and when they prospectively saw this patient even after 6 months to a year, these lacunae became greater, larger, and they when the microperimetry was done, they showed as larger scotomas corresponding to these areas. So a big question comes into play whether you really have to peel or you don't have to peel. The advantage what they say is like, since these scotomas don't come up and only about 17% are the recurrence rate, you just leave it as such, or whatever that has been passively peeled when during the ERM, you can just complete it and leave it as such rather than peeling actively. So it's again a controversy, not yet been proved. Coming to secondary ERMs, this is one which Mahesh sir has operated. This patient has a combined hematoma of the retina and retinal pigment epithelium. The few things which I would like to highlight in secondary membranes is, the problem is it is very adherent, densely adherent, so peeling is a bit difficult. You can get bleeding, abnormal bleeding also when you are trying to peel it, and the sub-peeling may not be complete. You might have to use other unconventional things which may not be required, like bimanual surgery in ERM, which we usually don't do in other idiopathic cases, and scissors also, which sir will be using in this to delaminate the membrane from the underlying retina. So this is the pre and post-operative. Hardly you can see any configurational changes as far as the retina is concerned, but the tractional pull and the disintegration of the inner retina can be well appreciated because of the CHRP secondary membrane. A new classification has come up, which is the OCT-based classification, which they are divided into grade 1, 2, 3, and 4, based upon the presence or absence of ectopic foveal inner retinal membranes at the fovea. So the more the traction by these membranes, the more the ectopic inner retinal which is there at the fovea. That causes the poor prognostic of the vision. So this is one of the representative cases. This becomes a grade 4 FL. So what they say, they have suggested is, if it's more than grade 3, it's better to do a surgical intervention, along with it give a steroid implant so that the contour attains much earlier and the visual prognosis is a little bit better as compared to surgery alone. The newer terminology which I wanted to spend a little bit more time upon, this is called as the LHEP. So LHEP is nothing but it's similar to an epiretinal proliferation, but different as compared to the ERM per se. It is a thick homogeneous medium reflective membrane. It's epiretinal. The margins of the lamellar defect is where we usually find it, and it's a non-tractional as contrary to the ERM which we have already studied. So the prevalence is approximately, high indences they have quoted about 30%. I have rarely seen them. I have just seen very closely after coming across this acronym about 4 to 5 cases in my clinical practice till date. The LHM may be associated with ERM or LHEP or both individually. So what is the difference? The most important difference that I would highlight is, in the ERM, the underlying retina is thrown into folds and there is a skip areas of contact and the cystoid spaces. As far as LHEP, there is no traction and it is tightly adherent to the underlying retina. So this is a representative image. The upper one is the LHEP, where you can see that the membrane is coming from the inner aspect of the hole and then growing onto the retina over there. As far as the epimacular membrane is concerned, it's pulling the fovea contour on either side. Theories is they say that it's vitreous in origin or mullacellular in origin. Both of them, it doesn't really say that, but when we do an histopathological analysis, it's more of a glial cell proliferation is what we have seen. So our experience, I would just run a video. So this is a stained membrane. You could see that it's very, very thick and very adherent. Sorry for the poor quality of recording for this video. It's very thick, very adherent, and you feel as if you are pulling out the inner retinal layers also along with this membrane when we are peeling. So this was the post-operative images. There's another patient with retinitis pigmentosa with LHEP in bilateral. So to conclude, epimacular membrane is a well-established criteria. There is criteria for diagnosis, OCT staging, as well as intervention, when to intervene and not. Only controversy exists whether to peel the ILM actively or not. As far as secondary epimacular membranes are concerned, the only issue is it's not easy to remove, and you have to be ready with adherent tissue to the underlying retina, and usually incomplete. LHEP has now emerged as a distinct clinical entity. Progression, the LHEP increases, the lamellar hole also increases, increasing in the EZ defects and decrease in vision. It's very challenging to peel these membranes because of the strong adherence to the underlying retina. And some reports have come out as favorable anatomical outcomes, as well as many of them have shown that there is no favorable outcomes with this peeling of this membrane, so they advocate just to leave it as such. Thank you.